Good afternoon, everyone. Welcome to this Hcc11 plenary session. I am Dr. Kogure from Tohoku Medical and Pharmaceutical University, and I'll be moderating this session together with Dr. Ninomiya from Tohoku University and Dr. Haga from Yamagata University. And he's somewhere, but he's online. Yeah, he's here. So we will have a series of presentations on tumor microenvironment in ACC. We will have 4 speakers covering a wide variety of topics, so we will take a few short questions after each speaker's presentation. And I will take care of the first 2 presentations, and Dr. Ninomiya and Dr. Haga will do the rest. Okay, so let's get started. The first speaker is Dr. Ueshima from Kinda University. So he is working on systemic chemotherapy for HCC and published many papers in this area. The title of his presentation is The Role of Local Regional Therapy Aimed at Improving the Tumor Microenvironment in Systemic Chemotherapy. Dr. Ueshima, please start.
Thank you, Tiana. I'm Dr. Ueshima from Kinda University. It is an honor to me to make my presentation here. And today, I would like to talk about the role of local regional therapy aimed at improving the tumor microenvironment in systemic chemotherapy for hepatocellular carcinoma. This is COI. This is the result of IMBRAVE 150 updated data. Median OS is 19.2 months in atezo-bev. Hazard ratio is 0.66 and p-value is 0.0009. And objective response rate is 30% according to RECIST version 1.1 and 35% modified RECIST. This is a Himalaya study. Durvalumab plus tremelimumab showed survival benefit over sorafenib. Hazard ratio is 0.78 and p-value is 0.0035. Median OS is 16.4 months in steroid regimen. This is objective response rate of durvalumab plus tremelimumab. Objective response rate is 20.1%. Despite the high frequency of IRAEs, the objective response rate is very low. Now, atezolizumab plus bevacizumab, steroid, and durvalumab monotherapy are available in Japan. How can the efficacy of immunotherapy be made more effective? It is reported that TACE may activate tumor immunity during immunotherapy. In this report, during tremelimumab, adding on TACE led to the accumulation of intratumoral CD8 positive T cells. And immunotherapy and local regional therapy have synergistic effects. Local regional therapy induces tumor antigens and increasing the effector immune response cells, inhibition of immune suppressive cells, and PD-L1 upregulation. In atezolizumab bevacizumab therapy, bevacizumab improves the suppressive microenvironmental changes caused by TACE, and the release of cancer antigens may enhance the efficacy of atezolizumab. Furthermore, it has been shown that there are differences in immune activation effects depending on the TACE method. DevTACE induces immune cells more efficiently than CTACE. So the significance of adding TACE on atezolizumab bevacizumab is to improve prognosis by controlling intrahepatic regions. This intrahepatic control TACE and release to release cancer antigens and enhances the effects of atezolizumab bevacizumab. This is called immune boost TACE. And 3, conversion purpose when a response is obtained. So to verify the effect of adding TACE to atezolizumab bevacizumab, what should we do? So I would like to introduce you the phase 3 impact trial. This trial is phase 3 randomized controlled trial to evaluate the efficacy of atezolizumab bevacizumab in combination with TACE. In Brave 150 trial, it has been reported that SD cases have shorter overall survival than CR or PR cases. It is necessary for SD patients to improve to PR or CR by adding the other treatment. This is the concept of atezolizumab bevacizumab in combination with TACE. Even though the patient achieves SD, the tumor will finally be a progressive disease. In case of SD, some additional treatment may be required to shrink the tumor. TACE seems to be very useful as an additional treatment. And long-term intrahepatic tumor control and anti-tumor immunoactivation are expected by combining intrahepatic control TACE or on-demand TACE that minimizes the decline in hepatic reserve. This is the study design of impact study. Eligibility criteria is unresectable HCC and child PA, and except for VP3 or VP4, 600 patients will enroll in the induction phase, and 3,015 patients in the randomized cohort at 100 sites in Japan. Atezolizumab plus bevacizumab is administered as an induction therapy for at least 6 weeks. If the patient achieves CR or PR, atezolizumab bevacizumab will go on. If the patient achieved SD, they are randomized and assigned to the intrahepatic control TACE arm or atezolizumab bevacizumab arm. Primary endpoint is OS in randomized cohort and conversion rate in conversion cohort. What is intrahepatic control TACE in randomized cohort? The purpose of intrahepatic control TACE is to reduce tumor burden and release neoantigens, which is expected to enhance the efficacy of atezolizumab plus bevacizumab. Standard TACE means total intrahepatic nodular embolization, but intrahepatic control TACE means embolizing some selective nodules to minimize the decrease in hepatic reserve. This is the schedule of atezolizumab plus bevacizumab in combination with TACE. After administration of atezolizumab plus bevacizumab, intrahepatic control TACE will be performed within day 15 to 28. Then after TACE, wait at least 7 days before restarting atezolizumab plus bevacizumab. The impact study is now ongoing in Japan, and please look forward to the results. And now we have achieved 25% of the patients required, recruited. And other clinical trials of immunotherapy and TACE improving tumor microenvironment. Many clinical trials are ongoing regarding combined immunotherapy and TACE. So EMERALD-1 trial met its primary endpoint of progression-free survival and was reported in ASCO GI this year. Emerald-1 is a placebo-controlled phase 3 study. Patients were assigned to durvalumab plus bevacizumab plus TACE, durvalumab plus TACE, and or placebo TACE. Median PFS was 15 months in durvalumab plus bevacizumab plus TACE and 8.2 months in placebo plus TACE. Hazard ratio was 0.77 and p-value was 0.032. This is REAP-012 study. This is a placebo-controlled phase 3 study. Patients are assigned to pembrolizumab plus lenvatinib plus TACE or placebo plus TACE. Primary endpoint is double primary PFS and OS. The result of this study will be expected. Emerald-3 trial is a placebo-controlled phase 3 study. Patients are assigned to steroid plus lenvatinib plus TACE or steroid plus TACE or TACE alone. Primary endpoint is PFS by RECIST version 1.1. The result of this study will also be expected. This is take-home message. Local regional therapy, especially TACE, acts on the tumor microenvironment and enhances the efficacy of immunotherapy. The IMPACT trial is ongoing in Japan to determine the additive or synergistic effect of atezolizumab and plus bevacizumab in combination therapy. The success of the Emerald-1 trial confirmed the effectiveness of the combination therapy of combined immunotherapy and TACE. So we continue to look forward to the result of combination trials of combined immunotherapy and TACE, such as REAP-012 and or Emerald-3. Thank you for your attention.
Thank you. Thank you very much, Dr. Ueshima. So, does anyone have questions for Dr. Ueshima at this moment? No.
Thank you for a very informative presentation, and also congratulations for your great success in intermediate stage HCC. I'm Dr. Lee from China University, Korea. I want to ask, in your real clinical practice nowadays, what do you recommend the best choice for the up to 7 out intermediate stage HCC to preserve liver function, also to control the tumor?
Thank you for your question. The best practice way to treat the intermediate up to 7 out patient. I think the systemic chemotherapy in combination with TACE or local regional therapy. So multidisciplinary treatment is necessary.
Which one is better, targeted or immune?
Immune therapy.
Better. Thank you.
Yes.
Thank you. It's Minong Yu from Kaohsiung. Thank you very much for the excellent talk. So, how to select the nodule? They are suitable for the so-called partial embolization. I mean, if they have many nodule spread both sides, how to select which one or which tool is the best to induce the using the neoantigen of the HCC to promote the A plus B efficacy.
Thank you. Tumors increasing tumors or the peripheral tumor in the peripheral site. So TACE is very effective. So it is important to perform test is not to reduce the hepatic reserve. So so まあ、not all nodules. So one or two nodules you can select.
So for the induction of the after bay before the implementation of the taste, what is the optimal duration? I mean, three cycle of the after bay or six cycle? I don't know. So do we recommend what is the optimal induction period with the after bay before we implement the taste for the patient?
Implement.
I mean, in your study, the impact study, you introduced the taste after confirm the patient have stable disease after the bay.
Yes.
So I mean, is the ultimate stable disease is 3 months or 6 months, or what is the ultimate duration of the stable?
3 months, 12 weeks, at least 6 weeks.
Okay, thank you.
So I have a question. So the effect of taste in terms of influencing host immune system. So you mentioned that taste could reduce tumor volume and also increase antigen of the tumor antigen by destroying tumor cells. And so compared to the ablation, radiofrequency ablation or something, so taste could induce hypoxia in the liver. So is that any influence to the immunotherapy compared to RFA or something?
I'm not sure. Maybe I think taste is better than RFA because RFA is a heat effect and change the protein structure. So antigen. So taste is
better for producing the tumor antigen.
Combination with immunotherapy.
Okay, thank you very much. So is there any question? Okay. Yeah. So thank you very much, Dr. Ueshima.
Thank you very much.
So next speaker, I introduce the next speaker is Dr. Min-Lang Yu from National Sun Yat-sen University, and he is a dean of the College of Medicine and also a vice president and chair professor of the university. And so I think he's a very famous person, and he has many roles in an international committee or international association, including APASO, and he is a very proliferative person, and he published more than 500 articles. So let's hear Dr. Yu's talk from now, and his presentation title is Cancer Prevention in Patients with Chronic ACV Infection. Please start, Dr. Yu.
Thank you very much, Mr. Chairperson, for your kind introduction. Good afternoon, ladies and gentlemen. This is the epidemiology of the hepatocellular carcinoma. As you can see, most of them are related to the hepatitis B or hepatitis C, especially in Japan, in Egypt, United States, and maybe in Europe. HCV has been the dominant type of hepatocellular carcinoma, at least right now. And even in Taiwan, where HBV hyperendemic, the HCV also accounts for 30% of HCC patients in Taiwan. So this is the natural cause of HCC in HCV. That's as you can see in the clinical practice, what you have to do is to block the progression of the HCV infection from chronic disease to cirrhosis and hepatocellular carcinoma. But right now we have no vaccine available, so it's difficult to implement the strategy of primary prevention. And what we can do is the secondary prevention that block the continuous inflammation from chronic hepatitis to cirrhosis and hepatocellular carcinoma. Because if the HCC occurs, it will be very difficult to stop the recurrence of HCC, even we have the very dramatic antiviral therapy. So during the past 30 years, with the advance of the antivirals, right now we can cure more than 95% of our HCV by the so-called directed antiviral agents, which have almost no any limitation for our patient population, whatever the liver function, whatever the comorbidity. But most of the interferon-based therapy and the DA-based therapy can remarkably reduce the HCC risk by 75% if we can cure the patients, eradicate the HCV, so-called achieving the sustained virologic response. However, if looking at the patient who have SVR after DA or even after interferon-based therapy, there's still a substantial proportion of the patients will develop hepatocellular carcinoma, indicating the HCC risk remain even after HCV eradication. So today I will focus on the unmet need of HCC occurrence after SVR by antiviral, and what impacts of the unmet need, and why it occurs, and who are at the risk, and how to monitor, why to monitor, and how to prevent. So in this example, as we saw in Japan, HCV is the predominant etiology of hepatocellular carcinoma. You can see it's the introduction of the DAA, the HCV viremic hepatocellular carcinoma decreased over time from 49% in 2009 to only 25% in 2017. But the HCC developed after SVR, the proportion of this patient population increased from 3% to as high as 6%, 16%. So when we looking back, what about the annual incidence of the HCV after SVR is quite different by the interferon-based therapy at the side bar, only 0.5% every year by interferon from our data, but up to 1.1% every year by USA data by the DAA therapy. But I think it's not due to the antiviral itself, but due to the broadened criteria, which are almost all the patients, however, patients with hepatitis compensation, advanced cirrhosis, have multiple comorbidity. All of this patient population could be cured by DAA, but it's not indicated for the patients to apply the interferon-based therapy. Therefore, it's not surprised the annual incidence of HCC will increase to 1.1% every year. So this large-scale meta-analysis demonstrates the HCC occurrence by DAA or by interferon. You can see almost the DAA study just only 2 or 3 years follow-up, and almost the DAA study have a much higher age population, and the age and follow-up duration, but not the antiviral agents contribute to the higher risk of HCC after SVR. So why this patient occur HCC even after the virus been eradicated? So this is the potential pathogenic mechanism of HCV-associated hepatocarcinogenesis, including the host pattern, such as advanced liver fibrosis, steatosis, diabetes, and genetic disposition. And several studies also demonstrate the HCV viral protein, viral co-protein, the non-structural viral protein, could unregulate the tumor suppressor gene, promote the activation of oncogene, and dysregulation of toxic ROS and immune mobilization. And also, viral host invasion could have lead to the epigenetic modification, hypermethylation of tumor suppressor gene, and alteration of the microRNA profile, which leading to inhibit the tumor suppressor gene. So if we evaluate the virus, we can evaluate the right factors, and you might have a partial reverse of the advanced fibrosis, insulin resistance, and we might reverse the epigenetic modification by the loss of viral host interaction. But interestingly, in our collaboration with Professor Gail Tanami in Bar-Ilan University at Israel, we found that the HCV infection lead to the histone 3 acetylation at the lysine 9, and this epigenetic modification reprogram the downstream gene expression, and the dysregulated aging signature was associated with high risk of hepatocellular carcinoma even after HCV eradicated. So in the cell model, you can see the epigenetic modification cannot be changed even after the virus was eradicated by the DAA. Similar study also reported by Professor Baumeister from France. They disclosed a so-called prognostic epigenetic signature, including 25 commonly genes in both HCV and NASH patients. As you can see, the dysregulation was more frequent in patients with advanced fibrosis than in patients with mild fibrosis. And the dysregulation of the so-called prognostic epigenetic signature was associated with higher risk of the HCC occurrence and associated with low overall survival. So we all know that the circadian clock control pathway is a regulator in the liver physiology and also responsible for some liver diseases. So this study also comes from Professor Baumeister. They used the transcranial analysis by the patient liver that demonstrated the HCV-induced epigenetic and transcription perturbation of the circadian clock control gene. They persisted even after the DAA therapy. They even eradicate the virus. And the hallmark analysis confirmed that most of the significantly perturbed circadian clock control pathway remain altered after the DAA cure in the paired liver biopsy. So naval analysis suggests that many of the dysregulated circadian clock control genes are members of cancer hallmark. So this data indicates there is a so-called hit-and-run scenario which involved in the HCC development of the viral eradication. We also try to evaluate whether the change of the cytokine in the high-risk population are also associated with the HCC risk of SVR. 97% of advanced fibrosis patients who the cytokine was determined at the baseline and the 24 weeks of annual treatment. We can see for patients with HCC development, the post-treatment level of TNF-alpha and the tweak was significantly lower than the patient without HCC development, indicating the loss of immunosurveillance of the SVR may be associated with HCC risk in the HCC patients. So it's very important to identify which patient population are at the risk of HCC after SVR, so we can follow this, monitor this patient carefully. So there are several studies demonstrating the risk at the baseline, including the non-keratotic nodule, significant liver disease, fibrosis, or the liver function baseline alpha fetoprotein or gamma GT level, patient possessing risk of genetic disposition, diabetes, and age. And even after SVR, several biomarkers can predict the HCV after SVR, including the fibrosis markers, alpha fetoprotein and LOT level 6 months of annual treatment, and also uncontrolled diabetes. So these three studies try to evaluate the lung-characterized liver nodule as a risk of HCC of the DAA therapy. All of these studies demonstrated if the patient have lung cancer and liver nodule at the baseline, they are at a higher, significantly higher risk of HCC when compared to the control groups. For example, in this study, you can see the 2-year cumulative incidence rate was 13.6% for patients with lung cancer liver nodule compared to those without, only 54%. And interestingly, you can see most of the HCC occurred during the first 12 months after the DA therapy. The second important risk factor is the fibrosis state. This meta-analysis includes more than 27,000 patients with cirrhosis and another 32,000 patients without cirrhosis. You can see cirrhotic patients had the highest annual incidence at 2.99, followed by fibrosis stage 3 incidence at 0.63, and the non-cirrhotic patient at 0.47. But if you're looking at the cirrhotic patients, the highest annual incidence was within the first year of the DA therapy, up to 6.17%, and followed by 2 to 3% every year thereafter. So it's very important to regularly monitoring the high-risk patient population, such as fibrosis stage 4 and with the lung cancer liver nodule before the DA therapy. We all know that the successful antiviral therapy could modify the severity of fibrosis after the SVR. So it would be very interesting to look at the dynamic of fibrosis status in the prediction of HCC. So we stratified the patient into 4 groups. The first one patient is mild to mild fibrosis after SVR. The second is advanced to mild. The third group is mild progression to advanced. The final group is persistent advanced fibrosis. As you can see, the hazard ratio increased from 1.99 to 7.47. So indicating the fibrosis change is very important, and very important, even higher, more important than the fibrosis at the baseline. So one interesting study tried to evaluate the role of so-called the fatty liver on the risk of HCC or metabolic dysfunction on the HCC of the SVR. This study tried to evaluate a genetic risk score of hepatic fat combination combined variants of 4 fatty liver-associated genes, including PNPLA3, MBOT T7, TM6SF2, and glucose kinase regulator. And they find that the patient possessing this for risk certainly are at a higher risk of the HCC, suggesting hepatic fat promote HCC of the SV cure. Another study demonstrated the patient with diabetes and without a metformin special, they were at higher risk of HCC. So these 2 studies demonstrate the metabolic dysfunction might play a very important role in hepatocarcinogenesis of the HCV eradications. So how to monitor the patient at risk? So this is the 3 major liver society, APASO, ESO, and AASLD. APASO recommend all the population every 6 months for 2 years for myofibrosis, then every 12 months, and every 6 months for advanced fibrosis with sonography plus tumor marker. The ESO recommend fibrosis stage 3 or 4 with every 6 months sonography surveillance, and the AA only recommends fibrosis patient, cirrhosis patient every 6 months with sonography with or without F-alpha protein. But in Taiwan, we are recommending advanced to have a regular HCC surveillance every 3 to 6 months for patients with advanced fibrosis. And for patient with fibrosis 2 or for patient with the other HCC risk factor, we have to have HCC surveillance every 6 to 12 months. For example, HCV co-infection, patient with dysplastic nodule, alcohol, diabetes, and the high LT gamma G level of the treatment. So why we have to monitor this patient population? Because when we analyze the characteristic and the survival outcome between the HCC that occur after HCC cure or they occur with concomitant with either the HCV viremia status, we found that for patients with post-SV HCC, the green line, have a significantly higher survival than the patient who develop HCC at the HCV viremia status. So we further found that the patient who develop HCC after SVR will tend to be older, more female, less frequency of alcohol smoking, and less liver inflammation and hepatic fibrosis, and also less proportion of metabolic disorder and comorbidity. And we found that the patient will have a early tumor stage, more solid tumors, small in size, and less metastasis, and they are more eligible for curative tumor therapy. And however, the pathologic feature of the resectable tumor were compatible between these two groups. So this data indicated the favorable clinical and tumor characteristics in the patient who developed HCC after SVR contributed to the better survival in this patient population when compared to the patient with HCV viremia. So this study tried using the micro-simulating model to evaluate the cost-effectiveness of biannual surveillance for HCC. For example, for advanced fibrosis, the annual incidence was 0.58. For severe patients, the annual incidence was 1.95. They found that for the advanced people, the cost-effective of biannual surveillance up to age 60 at 23 quality per 1,000 patients and detect 24 more HCC cases in very early stage per 1,000 patients. And in patients with cirrhosis, the cost effective up to age 70 at 77 quality per 1,000 patients and detected 130 or more HCC cases in very early stage per 1,000 patients. So both of the ICER fiber 124 to 129,000 in advanced fibrosis patient or 80,000 to 95,000 for the cirrhotic patient are less than the threshold at 150,000 per quality. So the SLA recommended the biannual HCC screening only for patients who have annual incidence risk of 1.5% or more. But this recommendation did not consider the low competing risk not obvious in people cured of HCV infection and did not include new HCC treatment option, and also use an all you need to pay threshold to figure whether HCC screening is cost effective. So the current Markov model compared the surveillance strategy of ultrasound alone or ultrasound plus of beta-protein compared to the no surveillance in 1 million submitted patients with a willing to pay threshold at 100,000 per quality. They found that an HCC instance of 0.4% or more, and the surveillance interference more than 20%, the biannual HCV surveillance is cost effective with the ultrasound sonography plus beta-protein compared to the no surveillance. Finally, I will touch a little bit in the how to prevent the HCC occurrence after SVR. In this large-scale study, we recruited more than 7,000 HCC patients of SVR for its follow-up up to 16 years. We found that with the patient have no diabetes, the 5-year cumulative HCC risk was 3%, which was significantly lower than the patient with diabetes but without the metformin treatment at 10.9%. But if the diabetes patient have a metformin treatment, the 5-year cumulative incidence rate could decrease to only 2.6%. So it's very important to implement the metformin for our diabetes patient. And also we found that several unfavorable risk factors, including the liver cirrhosis, age more than 65 years, male obesity. And another interesting data is that we found that for patients with hyperlipidemia and statin use, the risk of HCC will decrease. So in summary, the HCC risk remains after HCV eradication, partly due to the irreversible epigenetic scar, unchangeable genetic disposition, loss of the immune surveillance, and persistent comorbidity and unfavorable environment. If the patient have uncharacterized liver nodule and persistent advanced fibrosis, they are at a very high risk of HCC, especially in the first 3 years of HCV, and should be monitored closely. You said our HCC incidence ratio for cost-effective surveillance of HCV is mandatory for early identification for the new HCC. Metformin for diabetes patients and studying for hyperlipidemia patients could serve as chemo-preventive agent for HCV patients after SVR. Finally, I will invite all of you to attend the Apostle single topic comments on the MARFOD, it means more than a fatty liver disease in the end of this June. Thank you very much.
Thank you very much for the great talk. And so you talk covered all of the post-ACC. So is there anyone have a question for Dr. Yu in the floor? So could I have a question? So you mentioned so many factors as a risk for post-SVR-ACC, and I'm very interested in the methylation or histomodification by the SV infection. So the mechanism is common in the metabolic dysfunction-associated SCC?
You mean the methylation of the epigenetics correlated to the metabolic dysfunction?
Yeah, I mean, in the SCC arising in the NASH or muscle D. So, is there are there common phenomenon like methylation of the promoter region of the oncogenic gene or histomodification, dysregulation or something?
It's very interesting because recently we are looking at whether the MASOD or MARFOD have the impact on the HCC occurrence. But the data is quite conflict, quite discordant between the different sites. We know that the consistent finding is that the diabetes is universal the most important risk factor, but steatosis itself, especially the simple steatosis without any metabolic dysfunction, this patient population have even low HCC occurrence. Okay. So quite interesting. We also interested in whether the methylation or the epigenetic are associated with the metabolic dysfunction, but right now we have no data, so okay. We are working on it. Yeah.
Okay, thank you very much. And is there any question? Okay.
I have one question. And HCV-related HCC is still important problem. And do you have any idea or any way to reduce HCC occurrence after HCV SVR using?
Yes. So that's why that's in our last second's slide. First we have to look at the what risk factor the patient had, and try to find the modifiable factors we try to collect it. So you have to control, because the status of the diabetes control according to the hemoglobin A1C is also very important in the HCC occurrence. So it's very important to keep the diabetes well controlled. And interesting, patients have hyperlipidemia did not have impact on the HCC risk. But if the patient have hyperlipidemia and receiving statin, the risk of HCC will decrease. So it's very important. Maybe we don't need to fit the criteria of statin in the patient population. For example, in our country, it have the LDL-C greater than 130 and the total cholesterol more than 240. But maybe in this patient population, for cholesterol level more than 200 or LDL more than 100, we might apply the statin for this patient population to reduce the risk. But there's still lack of the evidence. So we need to more study to validate our concept.
Thank you.
So, okay, yeah, please.
Okay, thank you. Professor, I want to ask what's the cutoff for the BMI to determine the obese or non-obese patients? If can we use 27 or 23?
23.
Is it better for HCV?
Yeah, I think 23 is the Asia criteria for overweight, not for obesity. And and 2 years ago in the Lancet, a study demonstrated the best BMI for the long-term survival of fibril etiology is the BMI between 23 to 27. So it's not good to keep the body weight BMI less than 23, I think. Very, very interesting. There are a very large epidemiology study. The best BMI for the long-term outcome of human is 23 to 27.
Okay. So thank you very much.
Thank you.
Okay, next presentation is Professor Valerie Chu. She is from Taiwan, worked at Duke NUS Medical School, and she is a top runner and top runner expert in this field. And I'm looking forward to hear her presentation today. The title is Understanding Microenvironment for a Biomarker and Therapeutic Discovery in Hepatocellular Carcinoma. Could you start?
Thank you very much, and thank you for the kind invitation on Apostle and a very kind introduction. So I would just like to kind of respond to what Professor Yu have just spoken about. I guess I'm BMI less than 23, so I try to give my lecture just for tumor microenvironment. So I have no disclosure. So today I'm going to talk to you about tumor microenvironment. That's my area of research. And I also realize this audience is more clinical, and I do translational research. So I hope my lecture will at least bring you some knowledge in the tumor microenvironment. So we know that the HCC tumor microenvironment is infiltrated by different types of immune cells. So among them, some of them are associated to poor prognosis, some of them are associated with good prognosis. So for instance, we all know that regulatory T cells, these are the very immunosuppressive T cells, they are often associated to poor survival of the patient. Whereas some other immune cells, such as the cytotoxic CD8 T cell, they are often associated to good prognosis. But we also know the tumor microenvironment is very dynamic and they can change. So for instance, we know that the tumor can undergo evolution. So we know that genomically, they can actually get different mutation in terms of the genome landscape. But we also realize the immune landscape can also evolve accordingly. So for instance, we do not expect the immunosurveillance is active for a long time. So in fact, through tumor evolution, if the patient progresses with the disease, we expect the immune microenvironment will also evolve together. One of the hallmarks of tumor evolution in terms of immune microenvironment is actually very obviously it will become exhausted or immunosuppressive in nature. And so you can imagine it's like a constant battlefield between tumor and the microenvironment. So eventually, both of them will probably go into like exhaustion. So the immune microenvironment is known to go into immune exhaustion or suppression. And we also realized from other study that it can also become very heterogeneous intratumorally. So we know that genomically, through tumor evolution, you will have different mutation from one part of the tumor versus the other part. But likewise, the immune landscape can also become very heterogeneous in terms of one tumor parts to the other parts, they have very different immune landscape. But because of the interest of time, I will not talk about this study. I will just focus on the immune exhaustion and immunosuppression, and where there are several factors can actually drive this kind of immune exhaustion in the tumor microenvironment. For instance, hypoxia. So I think the first talk also talked about hypoxia. And we also know if you have chronic virus hepatitis B infection, it can also cause the tumor landscape to be very immunosuppressive in nature. And also a fatty liver disease. So I will talk about each of them a little bit. But also not forgetting, with treatment right now, especially immunotherapy, we can reverse the immunosuppression to become active. So I will start by talking about hypoxia. So we all know that hypoxia is a condition that's lack of oxygen in the tumor microenvironment. It is very harsh for the tumor cell, but also very harsh for the immune microenvironment. So we know that in the tumor microenvironment of HCC tumor, if they are high hypoxia, and for the region that we mark with hypoxic gene signature, we can see they are accumulated with a number of immune subset, for instance, the regulatory T cell. So I already told you that regulatory T cell is very immunosuppressive in nature, and they are enriched in the hypoxic HCC tumor microenvironment. At the same time, we observe that CDC2 subset is a dendrit cell that could, very well known to be able to present tumor antigen. However, this CDC2 subset, they actually lose the HLA-DR molecule, thereby suggesting they lose the ability to present tumor antigen. Overall, we are seeing a more immunosuppressive landscape for HCC tumor that is highly hypoxic in nature. We also realized that this Treg cell form a very close correlation with this CDC2 subset that lose HLA-DR molecule. And of course, seeing is believing. When we stain for these two subsets in the tumor microenvironment, especially in the hypoxic microenvironment marked by the white color staining, this is the hallmark of hypoxia, CA9. We can see that these two subsets, they are very close to one another. This is measured by the distance between them in the hypoxic environment. They are very close by to one another, suggesting they are directly interacting with one another. So what do they do when they interact with one another? In fact, we found that they undergo a mechanism called trochocytosis. This is a Greek term. It basically means that you eaten off a part of the plasma membrane from one cell and transfer to the other cell when they interact with one another. So this is exactly what we found happening. The CDC2 subset, when they're in the hypoxic microenvironment, they lose the HLA-DR, which is the antigen-presenting molecule. And this happens only with the presence of Treg cell. Without the Treg cell, they don't lose the HLA-DR. And where do the HLA-DR molecule goes to? They actually get transferred onto the Treg cell. And when the Treg cell gain the HLA-DR, they become even more immunosuppressive in nature. So we also check the RNA level of HLA-DR on the Treg cell. So then there's no increase in RNA. So the only way that they can gain HLA-DR is actually store it from the CDC2 subset when they interact with it. So in conclusion, we uncover this unique immunosuppressive mechanism in hypoxia when we also discover the transfer of HLA-DR molecule from CDC2 subset to Treg cell when it is lack of oxygen. So the second factor I want to talk about is actually chronic virus, hepatitis virus B infection. We know that chronic hepatitis B virus can actually cause immunosuppression in the tumor microenvironment. And by comparing the HPV-related versus the non-viral-related HCC tumor. So this is from our CyTOF data. We can find that the immune landscape are very distinct. I'll just point out two key distinct differences. In the HPV-related HCC, we are observing more Treg cell, again, immunosuppressive. And we also see resident memory CD8 T cell that express higher level of PD-1. So across the board, they have higher expression of PD-1 and as well as HLA-DR. So suggesting they are more immunosuppressed in nature, but also I think there's one hypothesis that we would like to bring out. With anti-PD-1 treatment, we will expect to see HPV-related HCC respond better because anti-PD-1 is known to outregulate the anti-immune functions of the resident memory CD8 T cell that express PD-1. At the same time, within the same study, we show that anti-PD-1 can reduce the immunosuppressive function of Treg cell. Overall, anti-PD-1 will expect to actually enhance the anti-tumor immune response, particularly within the HPV-related HCC subgroup. And of course, these have been validated later on in the Nature publication, where they show that viral HCC, in particular, HPV-related HCC, seems to respond better to a number of checkpoint inhibitors. I would use the word "seen" because I know this result is currently very controversial. Subsequent clinical studies have shown that there's not a lot of difference between viral versus non-viral. But of course, I would argue that the tumor microenvironment is very complex in nature. And one note to also take that our non-viral patients are mainly non-NASH in nature. So this particular Nature paper focused a lot on NASH-related HCC. That also brings us to study the fatty liver disease, which is related to NASH. I do not want to use the word NASH because non-alcoholic fatty liver has been word or the terms with a lot of kind of stigma around it. So I followed the ESL definition. We call it a steatotic-related, liver disease-related HCC. By definition, it simply have high fats in the hepatocyte with more than 5%. Our patients show sign of liver damage with fibrosis, and a lot of them also show inflammation. And they have no known history of alcohol, and all of our patients is also MAFO because they have metabolic disease. So comparing these two subtypes of patients, we can observe that these patients accumulate a whole bunch of CD4 T cell, but they lose the CD8 T cell. So this is actually where CD8 T cell is, suggesting these tumors are colder in nature, so they are cold HCC tumor. At the same time, they gain macrophages, so this whole bunch is macrophages, and they lose B cell. So overall, they have very weak adaptive immune response in the tumor microenvironment, and they are accumulated with immunosuppressive CD4 T cell, and majority of them are actually Treg cell, and they also gain macrophages, which is also known to be associated to immunosuppressive function. Currently, we are still working on our spatial transcriptomic analysis data, and of course, I hope to wrap up this story and share with you very soon. So now I want to switch gear a little bit. How do we then convert the very immunosuppressive microenvironment to become active again? So we can actually do this by applying at therapy. So one of the strategies is actually using radiotherapy. So in the past, a lot of people think that when you burn the tumor, you probably burn down to ground zero and you don't see any immune response. So we found that this is not exactly true because through the selective internal radiotherapy or radioembolization, so we give this, actually it's a Y90 radioparticle, a single dose is given directly to the HCC tumor where the hepatic artery. And it has a very short half-life of around 3 days, but when we see the response in the patient, it's often delayed, it's 3 to 6 month delay. And when they show a response, they are very sustained. So in our cohort patient, we do see sometimes more than a year or two. So we run these clinical trials actually with Professor Pierre Chow from Singapore. And to an immunologist, I thought we are seeing an immuno response. And so we collect the blood as well as the tumor tissue from the patient before and after Y90. So for the tissue, we collect them after they respond to Y90 and the tumor shrunk, and then we get a resection. And we subject them to, again, cytoph and RNA sequencing analysis. So first of all, let's look at the local tumor microenvironment after Y90. And to remind you again, this patient responded to Y90, therefore we get the resected tumor. And we see that accumulation of a different immune subset, a majority of them are cytotoxic or killer in nature. So there are natural killer cell, natural killer T cell, CD4 and CD8 T cell that express higher level of active immune markers such as CD69 or granzyme B. Whereas if we match with a treatment-naive control patient, so they have all the clinical parameter matched, but they do not receive any Y90 treatment, they are, as usual, are accumulated with regulatory T cell, which is the usual immunosuppressive cell. So that shows us that Y90 treatment can actually elicit an active immune response within the tumor microenvironment of the patient, especially for those who responded to the therapy. And then what about in the blood? Because we are always very keen to find peripheral biomarkers that can predict response to therapy because they're convenient and we can get them from the blood very easily. So we actually found out that there are certain T cells within the responding patient even before the therapy is given, and we can find them only highly enriched in the responding patient. And so these T cells actually express CXCR6 and CCR5. These are the two chemokine receptors suggesting that these T cells have the ability to home to the local tumor microenvironment. And therefore, they are actually enriched more in the responding patient as compared to the non-responding patient. So they are very significantly enriched, even out to 3 months after therapy. And do we have evidence to show that they do indeed home to the tumor microenvironment? And in fact, we do. So when we look at the tumor microenvironment of Y90 responding patient, and we find a whole bunch of immune activation response pathway have been upregulated. So this is the RNA sequencing data. And particularly, I want to mention the chemostatic activities also have been upregulated in this patient. And lo and behold, we found the chemokines that actually bind to the CXCR6 and CCR5, which express on the T cell that tell us they will respond to this Y90 therapy, showing to us that this chemokines is actually enhanced and enriched in the tumor microenvironment, thereby attracting the T cell from the peripheral blood into the tumor microenvironment. And in fact, we have evidence to show that the chemokines within the tumor microenvironment is indeed associated with the T cells that are active in the tumor environment after the Y90 treatment. So overall, the cartoon or mechanism of Y90 is that will be able to induce a number of immune pathway activation within the tumor microenvironment, particularly upregulate chemokines that can attract T cell to home to the tumor microenvironment, thereby giving rise to the clinical response to radiotherapy. And now I would also like to talk about another population of T cell, in fact, two populations of T cell that are also associated to Y90 response. In fact, they express PD-1 and TIM3. Now, these are the two checkpoint molecules, and that is very well known. We have anti-PD-1 now, we also have anti-TIM3 in the clinical trials. And these two are associated to response, so quite interestingly. And in fact, then we have an idea. If we combine radiotherapy with anti-PD-1, we could maybe expect to see even more enhanced clinical response to Y90. And we do these clinical trials with our medical oncologist colleagues from National Cancer Singapore, and the trial is still currently ongoing. And I want to talk about last project on using anti-PD-1 on our patient and identifying the biomarkers to predict response. And as well as in this particular project, we are interested in IRAE, which is the immune-related adverse effects. And just to remind you, the objective response rate is about 20% to monotherapy, and then we also observe around the same 20% of adverse effect. And because adverse effect is systemic event, is immuno-related, most commonly autoimmune diseases. Therefore, we actually collect the blood again to try to identify peripheral biomarkers. And in this particular study, we also collect the tissue, and we subject them to CyTOF and single-cell RNA-seq. And with the ultimate aim that we want to identify a mechanism that can give us enhanced response without the increase of toxicity. And true enough, from our CyTOF data in the blood, we are able to identify different biomarkers that are associated to response versus IRAE. But since we are interested to uncouple this effect, we are zooming into the population that zoom across response and IRAE, the common ones. So in fact, we identify two. These are the CXCR3 positive CD8 effector memory T cell, as well as antigen presenting cell that express HLA-DR. So they are related to response as well as toxicity. So this is quite reasonable because we think that antigen presenting cell and CD8 T cell would give rise to active immune response, both to response as well as to toxicity. Then how do we uncouple the effect within them? I will talk about it later. So first of all, I want to further strengthen the identity of these biomarkers because we do see them disappear from the blood over time after treatment. So we can see the antigen presenting cell and CXCR3 positive CD8 T cell reduce from the blood over time after treatment, suggesting they are homing to somewhere else. And where do they go? Of course, we thought it's tumor microenvironment. And indeed, our data do show that on therapy, after therapy with anti-PD-1 treatment, we see upregulation of antigen-presenting genes, suggesting the antigen-presenting cells are home to the tumor microenvironment. At the same time, we see the chemokines CXCL9, 10, and 11. These are the exact chemokines that bind to CXCR3 positive CD8 T cell, suggesting these T cells are home to the microenvironment because of this upregulation of chemokines. In fact, we are not the only one discovered such a signature. In fact, this publication in Cell, they studied more than 1,000 patients treated with checkpoint inhibitor across 7 cancer types. What do they find? Very similar to us. They found a whole T cell inflammation gene signature that are associated to respond to checkpoint inhibitor, among which also CD8 T cell. And CXCL9, which is the chemokine that we found very important to attract the population of interest CXCR3 positive CD8 T cell to the tumor microenvironment. And in HCC itself, in the JHAT paper by Professor Samjo group, they also again strengthened the fact that CD8 T cell are one of the key T cell elements that that actually associated to respond to the checkpoint inhibitor. And since I also mentioned that we want to uncouple the effect of response to IRAE, and we found that the antigen presenting cell associated to respond is actually CDC1 subset, is a dendritic cell. Whereas the one associated to toxicity is CD14 myeloid cell. Therefore, they are not the same kind of cell. That leaves us with only one type of T cell that is common between these two effects. These are the CXCR3 positive CD8 T cell, and we analyzed the receptor and ligand signaling pathway. We found that TNF receptor 2 are associated to response, but TNF receptor 1 are associated to toxicity. Therefore, we move on to the mice and show that if we combine TNF receptor 2 with anti-PD-1, they are related to response, and we can see enhanced response. Where the mice, they do not have any tumor at all. So in this animal, they are totally free of tumor. And what happened to receptor 1 that is associated with toxicity? We find that there are enhanced toxicity when we try to block them. So therefore, we don't suggest combining with TNF receptor 1. Instead, the receptor 2 that is only related to response, not related to toxicity, we can find that the T cell infiltration is not particularly enhanced compared to anti-PD-1 in red color here. And particularly, they do not express activation marker, which is 69. So therefore, this particular combination is the best. They give the best response without the increase of toxicity. So I will come to my conclusion. I have shown you that immunosuppressive microenvironment, or HCC, can be induced by various factors, so such as hypoxia, chronic virus hepatitis B, infection, fatty liver disease, and we also identify peripheral immune biomarkers to predict response to Y9D. And I also spoke about the predictive biomarkers for anti-PD-1 checkpoint inhibitor, and suggest that anti-PD-1 in combination with TNF receptor 2 could be the right combination to enhance response without the increase of toxicity. And of course, I thank my team for their work, especially Samuel and Aldo. My local collaborator, I work with David Tai, Supin Chiu, and Professor Pierre Chow, and my local and overseas collaborators worldwide. And these are my funding information. And I thank you for your attention. And I'm still waiting to see the sakura. So I've been promised that in the next few days I will see them. Thank you very much.
Thank you for a nice presentation on Dr. Chu. The microenvironment is very complicated and difficult to understand. But is there any question?
Yes.
Please.
Hi, Vardy. Kodama from the Osaka University. Excellent talk as usual. So I'm impressed in all the talk, but especially I'm interested in the middle talk, the Y90 stuff. So I completely agree the importance of the convert the immune cold tumor to the immune hot tumors by the local regional therapy. But unfortunately in Japan, we cannot use the Y19. So we can use other stuff, local regional therapy, such as RFA and TACE or RT. So do you have any idea, or do you have any data, the comparison, which kind of the local regional therapy actually, exert the T cell response?
So I wish we have data like that. So I welcome collaboration. Over at our site, I don't have my hands on TACE, after TACE therapy, tumor tissue. I would love to maybe work together. Okay. So I would like to study the different local regional therapies, but I believe maybe the fundamental mechanism might be quite similar to make the tumor hotter. And again, then you can combine with immunotherapy. That's just my hypothesis. Thank you.
And another question is, the last part is show that the CXCR3 positive, CD8 positive is important, the biomarker for the predictor of the PD-1 therapy. But nowadays we use a combination immunotherapy, so add on the VEGF, anti-VEGF. So have you ever also tested this biomarkers also predicting this combination immunotherapy, or you can see another different biomarkers?
So that's a very good question. In fact, a lot of people have been looking for biomarkers for Atezolbev. There are several studies already published, but we are looking in the peripheral blood. So far, what we can see is different immune population. It's not CD8 T cells, so it's quite interesting because don't forget Atezolbev is anti-VEGF and anti-PD-L1, not anti-PD-1. Anti-PD-1, the primary target is CD8 T cell, but Atezo-Bev, the primary target is not exactly CD8 T cell. We are seeing different immune cell that is biomarkers for this Atezo-Bev. But this work is ongoing. I hope I can share more data.
Yeah, I'm looking forward to hearing that. So,
Thank you.
Thank you.
Thank you very much for a great presentation. My name is Yamada from the University of Tokyo. I'm also interested in that Y19 the result, and as you mentioned that you can predict response of Y90 from the immunological evaluation, but do you have any idea? Because I thought that the Y90 is a kind of a radiotherapeutic effect, so so that could cause an apoptosis, so that is not immunogenic cell death. So do you have any idea how Y90 affects in tumor microenvironment in the aspect of immunological response?
So I think you are right in saying that Y90 does induce apoptosis. When we get the tumor from the patient, it's often way later after Y90. So usually the tumor will come back or they do not come back. So for the responding patient, the tumor strength and continue to be very small. Therefore, we get a resection and get the tumor out. Usually the time point is between 1 to 2 years. So that was like long after the Y90 is already gone. The half-life is only 3 days. So by the time when we look at the tumor, usually the tumor maybe still a bit apoptotic, but not really. So the environment has changed, however, from that single dose. So that's what we think that is quite interesting. Radiotherapy can actually modify the tumor microenvironment. Yeah. So at least for the responding patient. Yeah.
Thank you.
Thank you.
May I ask a question yet? And I'm a clinician, so I'm so interested for the time frame of the changing tumor microenvironment, because it's changing immediately, or we should wait a few months, because your study your study of the Y90 is taken different time of a few months after approaching Y90. So and how should time be taken in account to changing microenvironment?
Yeah, so we have a long discussion about this question. I think, again, it's a great question. So currently, the clinical trials design is such that we will give Y90, and 1 month later, we will start checkpoint. However, I do feel that it may not be the optimal time point, because after Y90, there's a lot of apoptosis going on in the tumor microenvironment. And therefore, the right microenvironment has not been re-established, so to speak. And we actually observe, at least in our data, from the blood, using different time point, we see the peak of the immunological response at 3 months.
Oh,
so
really?
again, there's a debate going on with my colleagues that should we maybe, in fact, start later than earlier for checkpoint after Y90. So I think this is a continual kind of research that we're still doing. Yeah.
Several combination therapy TACE plus PD-1 or PD-1 start a PD checkpoint inhibitor immediately after performing TACE. I'm so interested about that point. So thank you for
I think time point is very important.
Okay.
Good point. Thank you.
Thank you very much.
Yeah.
My question is the same. Okay.
Thank you.
Thank you.
Thank you.
Okay, so the last speaker is Dr. Sadahisa Ogasawara. His current position is Associate Professor, Department of Gastroenterology at Chiba University. He is leading HCC treatment in Japan. So I have been looking forward to hearing his presentation. His title is Tumor Microenvironment in Hepatocellular Carcinoma and its Optimal Treatments Approach. Dr. Ogasawara, please.
Yes, thank you for kind introduction. My name is Sadahisa Ogasawara from Chiba University, and I'm a great honor to speak this Congress after Barry. Okay. And also tumor microenvironment in HCC and its optimal treatment approach. I'm a clinician, so I want to talk about the tumor microenvironment based on the clinician's aspect. Okay. So this is my COIs. So what happened in the last 10 decade, 1 decade for the HCC? Around 2010, we only used about sorafenib, Of course, sorafenib have modest impact for the systemic therapy, but not a huge impact. But now we can use about a lot of agent for the clinical practice. And also the trend of the HCC moving on to VEGF TKI to immunotherapy. This is the current status of the advanced HCC. So we have to check about the data of the immunotherapy based on the outcome of tumor microenvironment, based on the outcome of the clinical trial. First of all, we try to assess the efficacy of the PD-1 monotherapy, but those studies unfortunately failed in frontline setting and both second-line settings. So in HCC, monotherapy had a less impact for the prolonged overall survival. Now we can have two combination immunotherapy such as atezolizumab and durvalumab. Those two regimens has improved overall survival superiority compared with the sorafenib. So now we are using a combination immunotherapy for the front line of the systemic therapy. So looking back at the development of immunotherapy for HCC, the mainstream of the treatment of advanced HCC has shifted toward immunotherapy. But high antigenic cancer like melanoma or non-small cell lung cancer where immunotherapy was developed earlier. So HCC was a little bit big behind about this kind of malignancy. And single agent ICI failed to demonstrate efficacy in clinical trial for advanced HCC. So we have to remember this point. Also, combination therapy of the ICIs with anti-VEGF antibody or dual ICIs were necessary to suppress the efficacy of the existing standard treatment of such as VEGF TKI. So let's look about T-cell activation, its suppression mechanism in tumor microenvironment. Now we do have two ICIs such as anti-PD-01 or anti-PD-L1 and anti-CTL antibody. Of course, as you know that anti-PD-1 or PD-L1 is effector phase, and also this kind of new anti-CTL for antibody affected priming phase. It means recruiting T cell to the tumor microenvironment. Also, we have already known about the other immune checkpoint molecules. So there are several drugs have continuing development targeting these kind of molecules. So, and also we have to know about the impact of VEGF on tumor microenvironments. As you know that the VEGF inhibition improves the immune suppressive tumor microenvironments. Of course, when we check about HCC's drug development history, the VEGF TKI works through the HCC. It means about HCC, a real VEGF-dependent tumor. That's why the HCC tumor microenvironment is so immune suppressive. So that's why we should use about the anti-VEGF antibody to the HCC's ICI combination therapy. Of course, you can see that if you use anti-VEGF antibodies to the HCC tumor microenvironments, those suppressive to the such kind of immune suppressive molecule of that kind of Tregs or M2 macrophage or MDSC. So that's why the PD-L1 antibodies such as the atezolizumab can work to kill the tumor. Okay. So HCC can be considered a VEGF-dependent tumor as evident by the efficacy of the VEGF TKIs in its treatment. So that's why the HCCs with a high VEGF signaling activity tend to have an immunosuppressive tumor microenvironment, and anti-VEGF inhibition are necessary for ICI to demonstrate efficacies. Okay. The two combination atezolizumab was a reasonable treatment development strategy. So of course, about based on the clinical trials, this clinical trials collecting tumor sample such as the INBRAVE 150 or the previous phase 1b trial, those data has really reasonable data. You can see that's high rate of the CD8 positive T cells population work atezolizumab very well. And also, if we find about RNA-seq data of effector T cell, of course, about great population for using about atezolizumab, and also if you use atezolizumab, of course, bevacizumab can canceling about Tregs, so that's why this atezolizumab works to the high Treg population or high myeloid population. So this data is really reasonable for the understanding about the mechanism of the atezolizumab. So combination therapy by atezo-bev demonstrate enhanced efficacy in tumor microenvironment, which in effect are T cell, particular CTLs. The presence of bevacizumab enhanced the effectiveness of the treatment is not dismissed even when factors contribute to the immune suppressive tumor microenvironment such as Tregs and MDSCs are present. So it's very reasonable for using about the HCC tumor microenvironment. Of course, when we understanding about the tumor microenvironment of HCC, only 35% of patients has a rich inflamed population, and other 65 population non-inflamed population. So it means about that's why the HCC is a big behind of the development of the ICI compared with melanoma or non-small cell lung cancer. Of course, cancer-specific T cell, it means CTL, I must work for the ICI to have anti-tumor effect. But unfortunately, I just demonstrated a few slides. ICI monotherapy is unlikely to achieve treatment effectiveness in advanced HCC, so that's why we have to use about combination immunotherapy for these malignancies. Recently, I found one paper from the Nature Med, and this data is really impressive for me that the presence of high-quality CTL, such kind of progenitor CD8 positive T cell and dendritic cell enriched mutation and regulatory molecule is necessary for expanding CTL. So this analysis, I check about the biopsy sample before. This study is conducted in neoadjuvant settings. That's why they collected tumor sample before starting nivolumab, and then after they collected resection sample. So that's why they can find about expanding of CTLs. And also, based on this data, high quality CTLs has necessary for working about RCIs. So, and those kind of data supported by the new cancer immunity cycle, such you can see here. Of course, interaction with the immune cells inside tumor is so important for the working about ICI. So now we have to, focusing on the quality of the CTL is one of the target for the finding about biomarker for these populations. So as a potential biomarker to identify patients who made response to effectiveness to ICI, confirming the presence of high quality CTL, but it's sometimes difficult to find this kind of population, I think, and so it could be clear. The next step is to undertake the challenge to collect and analyze in sample immediately before the initiating ICI treatment, but this is very challenging things. So now we are doing about such kind of challenge in our institution. We try to getting sample direct before starting ICI for using about such kind of methodology. First of all, we should need about large amount of sample for collecting for analyzing about tumor microenvironment by the biopsy sample. So we just using about this kind of needles and also collecting the the enough amount of samples and inject sponsor like this, and this kind of reduce the risk of the bleeding. That's why we can collect a large amount of sample based on the tumor biopsy. Of course, the clinical data and the clinical sample analysis will be collected, but now we are doing about such kind of approach, and maybe we cannot present the detailed data today, but maybe then ASCO or some of the next Congress we will present about this kind of data. So what happened in immunotherapy advance over time, we can use a lot of agent, but now in Japanese clinical practice, we can use about immunotherapy after immunotherapies. First of all, we are treating about, patient, maybe 80% of patients can use ICI in clinical practice. The other nearly 20% of patients cannot use ICI, but the majority of the patients can use ICIs. And also the data of the atezo-bev is also, data of the IMBRAVE 150 are also replicable in Japanese field practice. So maybe the atezo-bev works about median PFS nearly 6 or 7 months in general practice, and also ORR 28 to 30%. So maybe this kind of data are really working to the Japanese practice. And also, I would like to share another slide for the steroid regimen. This is one of the another combination immunotherapy, which we can use in clinical practice, so-called steroid regimen. You can see that 70 years old male non-viral patient, multiple interval hepatic lesion with lung metastasis. If we use a steroid regimen, you can see the AFP value here, really huge value of AFP value. If we use about steroid regimen 3 weeks after treatment initiation, rash and fever happen. So because if we use this regimen, it's so high occurrence rate of the immune rate adverse event. However, that you can see that dramatic response has happened. We have ever seen the other treatments. So maybe if you fit the tumor microenvironment and agent, you can see this kind of dramatic response in the patient. But now we have no biomarkers, so we have to try to identify who can experience, who can have this kind of response in the field practice. And also, I would like to show about another cases. And I'm sorry, he used about steroid in second line after atezolizumab. He's atezolizumab failure, 70 years old male patient. We tried to rearranging ICI in this patient. Maybe I guess that the PFS of the atezolizumab is 4 months or something. But after he started using about steroid, the metastasis around the neck is decreasing, and RECIST criteria maybe the PR in this patient. So I'm so surprising about if I use about steroid after ICI, some of the patient works like this. So now we have to think about we should rearranging ICI, or we have to after atezolizumab we have chance to using about durvalumab. So maybe some of the population have really great effect by using about anti-CTLA-4 agents. So those kind of biomarkers is really medical needs of the HCC treatment. Now there are several clinical trials conducting like rearranging of ICI after ICI, so I'm really waiting about result of this kind of trial. So one of the is targeting about TGF-beta1 monoclonal antibody, and this is another a mode of action of the agents. So those I want to check about these kind of clinical trial in the future. Let's move back to the Kaplan-Meier curve of IMBRAVE 150 and Himalaya trial. You can see that this kind of Kaplan-Meier curve is really closing in several populations. I think that in IMBRAVE 150 population, maybe 20% is effective population, and in Himalaya trial, maybe 35 to 40% of patients are effective of ICIs. So we need to understand that there are certain patients will not benefit from immunotherapy. Maybe those patients are, had immune desert population and never works about ICI. So we should exclude those patients do not using about ICIs, but that's why we have to find about biomarkers. So, and also I would like to share about another, two checkpoint, stimulate to inhibit two checkpoints such as the atezolizumab plus the anti-TIGIT antibody. This is another challenge to inhibit a dual checkpoint inhibitor clinical trial. So now we are enrolling this kind of clinical trial that we can check about the result maybe a few years later. And also next generation treatment for aiming for T-cell activation is one of the approaches is bispecific antibody. The another is CAR-T or TAR-T, and it means about if we are of course if the CTA is so important for the working about ICI, but this kind of treatment can aiming to T cell activation. So of course about a lot of advancement happen about this kind of treatment, but this is another challenge for the HCC treatment. Also, the immunoduration by the radiation therapy is another approach of the induction of immunological cell death by the RT induced by dumps, and also this kind of stimulation can moving back to cancer immunity cycle. So that why the transition to cold tumor, hot tumor. So this is a kind of another approach. So I'd like to introduce about one of the results from the clinical trial from the Mayo Institution. This is combination of particle therapy and immunotherapy. We present this data in ASCO GIs. We tried to do the phase 1b trial of the durvalumab plus tremelimumab with a particle therapy for the advanced HCC who had the macrovascular invasion. As you know that the patient who had a macrovascular invasion had an intra and extra metastasis. But generally, we clinicians has already known that the most malignant tumor is the node which had a macrovascular invasion. So we try to eradicate the particle therapy to only this main tumor. Then other tumor is treated by the durvalumab. So of course, they have the additive effective and synergical effect. So we do such kind of the clinical trial and also demonstrate our result. Treatment regimen is like this. In day 1, we induct the durvalumab and 4 times carbon RT, and after day 29, durvalumab monotherapy will continue until the disease progression. So surprising that if we eradicate the carbon RT in day 8, the majority of patients had a high fever. Okay, this is really surprising that we eradicated carbon RT after ICI. The majority of patients had a fever. So maybe in some of the immunological changing may happen in the tumor. And this is one of the results. Of course, the PFS is 3.8 months, and almost and also the 1-year survival rate is 87.5 months. Of course, it's not a good, but this is the patient who had a macrovascular invasion and also a lot of extrahepatic metastasis. So of course, we have to check about the detail data. Is there any synergical effect between particle therapy and ICI? But this is one of the strategies to improve the clinical outcome of the highly advanced stage HCC populations. So last slide, we are now entering an era which advanced HCC treatment involve developing strategy by selecting different approaches, include 2 combination immunotherapies. However, in HCC, where a large population of patients do not have immune cell infiltrate, both treatments have an integrated therapeutic effect in some patient groups. So in this search for biomarker to identify subgroup of HCC patients who are likely to respond to ICI, the presence of a high quality CTL could survive the several clinical starting point. In the future, it is desirable to develop a treatment focus on activating T cell in patients with advanced HCC. So thank you for kind attention for today. Thank you very much.
Thank you very much, Dr. Ogasawara, for your excellent presentation. So, are there any questions or comments? Yes. So I have a question. So, I'm interested in the CAR-T therapy. So, what are the current barrier to the effective implementation in HCC treatment?
One of the targets is maybe Gripcan-3. Several studies have already conducted in China, but this, all of those data was phase 1b trials, so we have to wait about data in the near future. And also, we have another question in the floor, so please ask.
It's okay.
Okay.
I was wondering where the voice come from. Hi, thank you for a very comprehensive talk. So I'm just curious about, because you mentioned about biomarkers as well. So in your opinion, or as a clinician, so do you think that tissue biomarkers is the hallmark and it will go on like that for the future as well? Or do you think that there is a lot of potential for peripheral biomarkers because, there's cell-free DNA and a lot of development currently?
That's a good question. because now we are focusing on the collecting tissue sample. Of course, if we check about the response by the PBMC or something, it's okay for us. It's easy to use. But I'm really thinking about liver is an inflammation organ by huge volume. So if you check about PBMC, so where the immune cell come from. Okay, this is one of the topics. So first of all, our approach we first of all check about tissue sample, then we want to moving on to the PBMC. So.
Thank you.
So are there any questions and comments? Okay, Dr. Wasawara, thank you for your excellent talk.
So thank you very much.
So may I close this session? Okay, so now we would like to close this session. Thank you very much.
Thank you very much, the moderators and discussant.